Good morning. For those of you who do not know me, I'm Federica Williams of Whittier Street Health Center. Thank you for being here this morning and welcome to all of you. We have a wonderful program. We'll have a keynote speech from the Executive Director of the Boston Public Health Commission. We have a panel discussion. You'll get to meet the all-star Whittier Mobile Tri-Diagnosis Health Outreach Team later in the presentation. We received funding from the Substance Abuse and Mental Health Services Administration to expand our program focused on addressing HIV, substance abuse, and mental illness among the most vulnerable populations in Suffolk County, including Mass and Cass. This is work our team has been doing for several years. As a matter of fact, we launched our mobile health van program starting with the HIV team in 2018. And the investment of Shamsha in our community will allow us to expand our mobile health programming, which removes barriers to care and meeting people where they are. Instead of us waiting for them to come to us, we're going to the locations where people congregate or where they live. Our mobile tri-diagnosis outreach team, who you'll get to meet later, will provide services and resources to those with HIV, those battling substance use disorders, and those battling mental illnesses. This will allow us to help to reduce new HIV infection amongst the targeted population, identify and effectively intervene with those who are at risk for substance use disorders, increase patient education, screening, and linkage to treatment options, healthcare, and social services for those at risk. The team intends to address these issues throughout the communities we serve, including the areas I just mentioned that people refer to as Mass and Cass. We know that Whittier Street Health Center must work in conjunction with other local and state agencies, and we've had a long-standing relationship with the city, especially working with the Boston Public Health Commission to address these deep, complex, and long-standing issues that has been plaguing our community. We cannot do it alone, and we rely on our partners to work with us to help to make a difference, because we know that together we will make a difference. The main goals of this particular program that we're expanding, we are calling it a tri-diagnosis program, is to reduce new HIV infections among the targeted population and increase the number of people who are aware of their HIV status, identify and effectively intervene with those who are at moderate or high risk for substance abuse and refer them to comprehensive risk reduction counseling and treatment, increase patient education, screening, treatment options, care coordination, because most times when people go into treatment, they need the support. They need people to help them navigate the system. And we have a wonderful team of care coordinators, and so do other healthcare providers, and risk reduction for substance abuse clients. Increasing access for high-risk patients with substance abuse problems to substance abuse services, including ours, whether they need detoxes or intensive inpatient, but we also have outpatient services, including our medication-assisted treatment program. Boston has a great need for this program. I don't have to tell all of you that. And this also, when you look at the prevalence of HIV in Suffolk County, is 938 per 100,000 people in Suffolk County, which is almost triple the rate of the rest of Massachusetts, with the highest concentrations of HIV incidences occurring in the South End, Roxbury, Jamaica Plain, and North Dorchester. And this is part of why we started the work and actually reached out to SAMHSA in 2018. And persistent pace, things came out to fruition this year. The issues of HIV transmission, which is why we have Dr. Bisola here, and substance abuse are interconnected in this area, as those who are at the highest risk for infection are those who share needles. Through this program, Whittier will be able to help to combat both issues at once, HIV, substance abuse, and also the underlying factors. Not only will this program address major health issues, but it is also designed to treat the underlying issues, social issues, housing, employment, mental health, those that are by connecting individuals to behavioral health resources, and you get to meet some members of our behavioral health team to help them avoid behaviors that put them at risk for HIV and substance abuse. Annually, our dedicated outreach team, they do such a wonderful job. I know Christine is going to be introducing them, and before you meet them, I just want to give them a round of applause, because they are out there every single day. Every single day, all through the pandemic. Even when we had a shutdown, we were all here, and this team worked tirelessly every single day. We have too many all-stars, but since they're in this room, I'll tell them that they are my all-star team. The others don't need to know that, don't tell them. So annually, our dedicated outreach team will provide over 300 HIV tests, in addition to distributing 20,000 condoms to these targeted populations, with the goal to refer patients to Whittier's comprehensive healthcare and social services, whether it's helping people with connecting them to housing, to jobs, to skills development, food pantry, behavioral health. A lot of these folks also have other chronic conditions, diabetes, hypertension, connecting them to those cares, but also working with other providers based on the needs of the patients. You all know that the need for this program is great, and Whittier is happy to be part of a solution. There are many solutions. This is a very complex issue, and we've worked closely with the city and the Boston Public Health Commission, and it's a privilege to be part of the response to addressing these issues so we can eliminate these issues and help people gain productive, healthy, and happy lives. So thank you, and we look forward to working with all of you. So moving right along, it is my pleasure to introduce to you a colleague, a friend, a role model, a leader whom I've known for many years, and it was just thrilled. As a matter of fact, I have the prepared introduction, but as we were going through this, the application for the SAMHSA, and really presenting, because SAMHSA focuses on substance abuse and mental health, and we were able to pitch to them the linkage to HIV. Once we submitted the application, I started having conversations with Dr. Bisola Ojikutu. Dr. Ojikutu is the executive director, the newly minted executive director of the Boston Public Health Commission. The Boston Public Health Commission is the oldest health department in the United States, and its mission is to protect, preserve, and promote the health and well-being of Boston residents, particularly vulnerable populations. And that's where we've enjoyed a wonderful, long and productive partnership with the Boston Public Health Commission. Dr. Ejikutu is also a physician leader with more than 20 years of experience in public health, health equity research, and the clinical care of infectious diseases. She serves as an assistant professor of global and social medicine at Harvard Medical School. She's also an associate physician within the Division of Global Health Equity at Brigham and Women's Hospital and a faculty member within the infectious diseases divisions of Mass General Hospital and the Brigham. Her work is focused on overcoming the structural and psychosocial factors that promote infectious disease risk among marginalized populations in the US, including COVID-19 and HIV, and that's where we've partnered because the marginalized population is our priority population, and preventing these issues has also been something that we've been pioneering for many years. Dr. Ejikutu was the director of the Community Engaged Research Program and the associate director of the Biobehavioral and Community Sciences Core within the Harvard Center for AIDS Research. She's board certified in infectious diseases and internal medicine. Please join me in welcoming Dr. Ejikutu to the podium.
Thank you, everyone. I just want to say that President Williams, Frederica, has been someone who I've turned to over the years for mentorship and for guidance, just as I've tried to navigate the world of leadership, and leadership as a woman of color. So I really appreciate her role and her experience here in Boston. I want to actually start by congratulating all of you on winning this grant. I think it's very difficult to get this level of funding. It's really impressive work that you hope to do. And I want to say that the Commission has been a long-term partner of Whittier as an institution here in Boston, and we hope to provide any and all support that you need to make sure that your work is successful. So I want this to be the beginning of the discussion, certainly not the end. So I'm going to bring up my presentation. Okay, so I'm going to run through a number of topics, and I'm not going to spend a lot of time on them, but hopefully, they'll give you a sense of what I'm thinking and what the Commission is thinking in regards to these issues, and also give you a sense of how we can collaborate and how we can work together. So first, I'm going to talk about state and local data regarding substance use disorder. I think that's a primary piece of your grant work. And then I'm also going to talk about why using a health equity framework and a racial justice framework are really critical to doing the work that you are hoping to do. I'm going to talk about the intersection of substance use and HIV in Boston. As Frederica said, I'm an infectious disease physician. HIV has been the core body of the work that I've done throughout my career, and so it's really important to make those linkages and understand what it is we're trying to accomplish. And then lastly, obviously, mass and CAS, as people colloquially call it, the encampment areas is probably more appropriate. It's on everybody's mind, right? We know that this is a huge problem. So I have some sense of what's going on, and the Commission has been doing a lot of leadership in that area, and I'd like to tell you a little bit about the work that's being done. So hopefully this will all be of interest to you all. So starting with some data. Essentially, and unfortunately, we have an increase in opioid-related deaths, both statewide, Massachusetts, and in Boston, from 2018 to 2020. In Massachusetts, from 2019 to 2020, there's been a 5% increase in opioid-related deaths, and in Boston, 2019 compared to 2020, there's been a 24% increase. So this is a problem, obviously, right? And a lot of things have contributed to it, and we'll talk about that in a moment. So let's turn to race and ethnicity, because I think that, again, using a health equity and racial justice framework to look at this work is really critical. And it's something that we tend to miss in regards to opioid use disorder. We don't talk about it as much, but I think it's really important for us to think about. I mean, here we basically have what's happening at the state level, and you see that if you three groups of bars to your, from your left over. You see Black, non-Hispanic men, and you see that the rate of death was 22.1, went up to 38.8, so that's more than a 50% increase, okay? So that's huge, okay? And that's Black, non-Hispanic people in general. If you look at men, and I think this came out in the Boston Globe probably last year sometime, you see that there was an even greater increase. So it went from 32.8 up to 55.1, and that means that Black non-Hispanic men had an opioid-related overdose death that was greater than white males. And of course, you look at Latinx men, you see that it's the highest overall. And this is, again, this is just men. All right, so what's going on here in Boston? Because that was state-level data. So these are confirmed opioid-related deaths over time by race and ethnicity. And what you see here is incredibly disturbing. So percent increase 2018 compared to 2020 amongst white individuals, 1%, amongst Latinx individuals, 11%, amongst Black individuals, more than 200%, 229% increase, okay? So right there, that should make you wonder, okay, what exactly is going on here, right? So let's talk about that. So I'm giving you a blank screen here, not because we don't know what's going on, but because I want to just think this through a little bit. So the proximal reason is that we have fentanyl. It's all over the street and it's killing people. But that's killing just about, it's killing everybody, right? I mean, it's not like that's just in, certain people's, laced in certain people's drugs. That's really killing everybody. But what could be different here? Because there's this interesting narrative about Black people not necessarily being, at risk for the opioid epidemic because, well, people haven't been giving Black people opioids because, we know that there's been disparities in pain measurement, right? So doctors haven't been, and I'm pointing at us because I'm a doctor and I know this is what we do, we haven't been acknowledging the pain and giving Black people pain medication. So then wait a minute, we don't have the predisposing risks that everybody's talking about. But think about that for a second. What would that tell you? People with pain disorders are not going to be sitting around in pain. They're going to go out to the street and they're going to get illegal medications, and that's what puts us, Black people, as well as Latinx individuals, at higher risk, okay? So that's huge, and we need to pay attention to that going forward, especially as more and more fentanyl and other synthetic opioids are available on the street, because that's what's happening. Okay, so let's now talk about some of these structural issues, because I said that was a proximal. When I mean proximal, I mean that's what we can point to and we can try to fix immediately. But there are bigger, broader issues that we need to be talking about here. So we need to be talking about structural inequity. Structural inequity is not just something that affects Black people or Latinx people or people of any certain race. We have lots of groups who are vulnerable, right? We have gender identity, we have class, we have sexual orientation, we have people with mental health disorders, people predisposed to addiction, people with disabilities, people who are non-US born or immigrants, okay? So lots of people are treated inequitably. Okay, so this is not just about race, it's about a lot of these other factors. But then when you compound that with race, you put structural racism on top of that, and you have some really serious problems, okay? Because you're talking about what we call intersectional issues, okay? We have race, we have ethnicity, and we have all these other problems that then create and compound these disparities that we're seeing. I like to use the term structural violence. That really hits you in the head though, right? But this is violent, right? Because these are the things that are causing people to have increased morbidity and mortality year after year after year. These are the ways in which social, economic, and political systems expose particular populations, whether they be Black and other things, or these other categories, to all of these issues that put them in high risk. This is what created what we're calling mass and caste down the street, okay, structural violence. So these issues of structural problems have led to systems failure. So systems failure, what do I mean by that? So we all know the healthcare system has failed lots of groups of people. I know my people, just doctors, my people, we've done some things wrong. We failed to treat addiction. We failed to prevent addiction. We've failed to treat mental health disorders. We've treated people inequitably, okay? That is what has happened. We've had unconscious bias and we've had very conscious bias. And this is what's happened in our healthcare system. The criminal justice system, what do we know about the war on drugs and what it's done over the years? And certainly it didn't go away because people rolled it back, because you have people who have warrants on them, you have people who are carrying histories and baggage with them from being involved in the criminal justice system. We have mass incarceration. We also have federal housing policy that's failed. We have an educational system that's failed numerous people, and we have the foster care system, which people don't really talk about very much, but that's really failed people, I mean, that's really led to people being at a higher risk, and they're on the streets. And that's the failure. That's what I'm talking about when I say systems failure. What that does is it leads to increased risk, poor outcomes, and the situation we have down the street. Okay, so let's bring this around to HIV. So this is the number of HIV infections among people who inject drugs by year in Massachusetts. Now, just take a step back, and what do we see here? So things were kind of going down, 2010 to about 2013, and then into 2014. So we were going in the right direction. Then what happened, right? So you see an increase from 2014 up to a peak of 2017, and then down from there. So what story is that telling you? Well, most of you all, because you're in the healthcare system, you heard that there was this HIV transmission, this cluster, this outbreak. It started in Lawrence and Lowell, ostensibly. We think it started in Lawrence and Lowell. That's where the outbreak, that's where everybody, came, looked at the issues, tried to figure out what was going on, but it certainly didn't stop there. But let's look at what happened in Lawrence and Lowell just for 1 second. So we had total new HIV infections during that cluster period, during when we had that outbreak, 129. Most of those are people who inject drugs, but there was also sexual risk, right? Obviously, you don't just keep things in one transmission factor. But what I want to point out here, that oftentimes, again, is part of this narrative that we put around opioids. Oftentimes, we say it's about men, and we see men, and we forget about the unique risk that women experience. Why do they experience that unique risk? Well, there's gender inequity, there's intimate partner violence, there's transactional sex, and that means that many women are second on the needle. Now, that means that the man may be getting something, may have something, and then that is then going to the woman. This is what we know is happening out there. Okay, so we have to think about the unique risk that may be impacting our different populations within the group of populations that we're interested in helping. So it wasn't just that there was Lawrence and Lowell. Certainly, there has been a Boston cluster that's still being investigated. Now, I think there are upwards of 113 cases that we've seen as an increase based on people who inject drugs and the comorbid risk and all these structural inequities that we've talked about. So this is another cluster here in Boston, and it's sort of an ongoing investigation. Okay, so what's being done about this? So Frederica mentioned, obviously a lot of people have been working, not just in the city of Boston, but in Suffolk County, looking at EHE. So what's EHE? So that's ending the HIV epidemic. That was the initiative that was started when Trump was president, when Mr. Trump was president. And during that time, this is one of the things that he initiated. He put a lot of money behind EHE, and it's very geographically focused. So some came to Suffolk County. So people are working on this intensely. Now, the goal is great, reaching 75% reduction in new HIV infections by 2025, reaching 90% reduction by 2030. That's all great. And in fact, the way it's laid out is not bad. It's all very proactive. We're going to diagnose, we're going to treat, we're going to prevent, and we're going to respond. But what did we just talk about? All those other issues? This doesn't really mention those other issues, right? But think about it, because that's not the framework that was being used as they were talking about these issues, okay? So that's not to say that we here in our EHE program in Suffolk County, and certainly Whittier, and we're working on these issues. We've worked in social determinants, we've worked in these structural issues, but that wasn't the initial framing of the initiative. So just so you understand, we've used the money and we're trying to work on it from a broader perspective, because you have to do the root cause analysis. You have to go back to what really caused the problem, not just diagnose, treat, prevent, and respond. Okay, so Boston Public Health Commission, you all know us. We're the local health department. We have these, 6 bureaus, and our mission is to preserve, protect, promote our most vulnerable populations. And in that respect, we are very much so focused in on structural determinants. That's structural inequity, that's structural racism, that's structural violence. All 6 of these bureaus are focused in some way on those issues, and all 6 of those bureaus are in some way focused on the issues that you'll be working on within your grant. I want to talk the specifics, though, because the reason why I want to talk the specifics is because I want you to be involved in what we're doing. We want a coordinated response, okay? So different pockets of money are going to different people, but we need to work together, otherwise we're not going to get this situation or any other situation sorted out. You all understand why I don't like talking about a corner, right? I mean, that's like dumb, We know that this problem is not just about a corner. People have migrated to that particular corner, and when they are moved, if they're not moved appropriately into housing, they will migrate to another corner. So why are we even calling this a corner? So anyway, that's just me. I think you all understand that though too. Okay. So So this is what we're doing at the Boston Health Commission in conjunction with the city, in conjunction with HHS. We have outreach workers. These are some really dedicated people, because I don't know if you all have taken a walk down through that area. This is tough. Okay, this is tough. These people go out. Yeah, they've gone out. I know they have. So this is tough work. Okay, and a lot of these folks, they have their own histories. They're in recovery themselves, and this is just can be triggering. You know what I mean? This is tough work. So we have outreach workers. They're canvassing neighborhoods. They're helping individuals to access care. I went out with them. They're lancing abscesses. They're giving people medication. They're in the tents with people. They're really doing it. We also have an engagement center. So you all probably saw that. There's a big tent. The reason why they have an engagement center is so that people can come in. They can get food. If they want to go into recovery, they can ask for help. They have computers. People can get their phones or charge their phone. It's really good. We're going to move from the tent to an actual building. This is a good thing, right? This is definitely a good thing. We also have the AHO program, which is how we're doing clean needles, doing harm reduction, naloxone, other testing in terms of HIV or STIs, hepatitis. So that's great. Okay, we also have the PATH program, which is placing people who want to access treatment, because not everybody wants to access treatment or they're not ready to access treatment. That is the program that's going to help them with that. And then out in Mattapan, if you haven't been to the Mattapan campus, we also have residential treatment programs out there. So if there are people out there who are getting services, they can stay there, they can live there, and I think that's really great. And it's really a peer-to-peer recovery program. That is how we destigmatize what people are going through. Okay, so again, I'm telling you all this because I think that some of this overlaps with what you're doing, and we can work together, learn from each other, and really, create something great out of all of this. Okay, a lot of this is about doom and gloom with Mass and Cass. If you open up the Boston Globe, now, I love the Boston Globe. I read it. I think it's great, but it's just you want to sometimes hear a good story, right? So I'm just going to share a good story that came out of some of our work. And I'm hoping you all can feel what I'm saying in terms of you got to have the positive stories. So this story is about J&E, that's a couple. They were experiencing chronic homelessness several years ago, but they were starting several years ago. They also had substance use disorder, but as a couple, they wanted to stick together. Okay, so they said as a couple, we're going to be together. They lost their housing, but they didn't want to lose each other's support. They were committed to each other. But like other couples who are dealing with homelessness in Boston, they were at a crossroads, because if you all know this world, you know that shelters are segregated, right? So the men and the women, they don't cross. They're oftentimes in totally different buildings. There are very few opportunities for people to remain in relationships, and relationships are important, right? So they decided instead of doing that, we're going to spend the night on the street. We're going to be outside. We'll either be in a tent or we'll be uncovered, down at the corner at the encampment area. So one morning, our recovery bureau director, Devin Larkin, she noticed that Jay, one of the male in the couple, actually came to the recovery center area, and he said, I'm really in some pain, my back hurts, things are just not going well for me. He went to the hospital, was offered some housing, but he said, no, again, I'm not going to housing without E. I'm just going to go back to the street. So at that point, what Devin did was she basically referred them to our housing list. Now everybody says, oh, there's not housing, there's no way out. The housing list and our housing activities, they actually do work. They don't work for everybody, but they actually do work. So they were able to eventually find them housing. They went into recovery, both on methadone daily. And the end of the story and the moral of the story is that there's hope here. This isn't just about what's, wrong. There is this idea that if you do a friendly touch, if you reach out and help somebody, that can work. We haven't lost that as a society. That can work. So I just want to make sure that we do hear positive stories. Okay, so I want to talk about the specifics of what's happened in the last couple of weeks, because the commission has been at the center of a lot of this. You know that on Tuesday, we, as the commission, issued a declaration of substance use disorder, unsheltered homelessness, and related issues. So related issues being mental health issues, HIV, all the issues. And what that did, what those orders do, because they don't always explain that in the news, what that order does is it basically says that I can now take the resources that are in other areas and move it into this because we need all hands on deck. Just like with COVID, just like with COVID-19, that's what we did. So simultaneously, Mayor Janey signed an executive order. Now the key piece there was saying that we're doing this as a coordinated team. This isn't just the commission, this isn't just any entity. We're going to do this as one. And one of the main things that she did was that she created a coordinated response team. So the central coordination team for mass and cast, for the encampment, for the street corner, okay? And so this team has started meeting. And I think those of you who've probably done this work before, like, okay, there have been a lot of meetings, so what's different about this meeting? The point of this meeting is that this really is a coordinated effort with the state and the city. We're working together. I was on the call on Tuesday. We had a call on Thursday. I'm leading the calls with HHS and Chief Marty Martinez, as well as the Chief of Staff in Mayor Janey's office. We actually said, look, this is going to be solutions focused. We are going to find out how many houses, how many low threshold houses. Now, the low threshold means that we're not requiring people to be sober to go into this housing. We're not requiring people to necessarily participate. We're not checking warrants. We're not doing any of that. We're giving people a roof over their head, someplace comfortable. We're making them human. You know what I mean? We're treating people with the dignity and respect that they deserve, and realizing that substance use is extremely difficult to combat. You cannot put people, everybody can't go to a detox bed immediately. Okay, that's not the way this works. So we're coordinating that effort, which I think is incredibly important. It's at its beginning stages. So it's not as though we currently know all the details, but I'm emphasizing, and I'm hoping this is what will be picked up, is that there's a central coordinating team, and we're working closely with the state on this process. So that's really the message I want to leave behind. And I'm going to actually stop there, because I think that there's a lot of work that you all are doing. I want us to continue this conversation at a later time, and I want you all to work with us closely on this, because all of us have a stake in this process. And I, again, really congratulate you and appreciate all the work that you're doing. So thank you.
Thank you. This was fabulous. This was wonderful. And as Dr. Ojukutu mentioned, the coordinated team, Whittier is also a part of the coordinated provider team. And they've even gone one step. We were meeting every week, and now we have a regular schedule every Thursday at 1 p.m. with a group of people to do this. So this was, looking at the structural issues, looking at the inequities, looking at the racial issues, is really the underlying factors that we have here. So this was just wonderful. Any questions? She covered it. And I saw some of you taking pictures. We have the presentation. Can we share?
Yes.
Yes. So you'll have the presentation, but this is the kind of information. This is, as you said, yes, there's kind of a doom and gloom focus, and when you do that, sometimes people become overwhelmed and not focused. But together, this team, been working with your team in all of those offices that you mentioned, they are closely aligned. The city has supported us in the work that we're doing, and there is hope. And I loved that individual story of that couple, because that's really the crux of the matter, that if we look at people individually, if we look at the systemic issue, if we look at the underlying issues, all together with our combined efforts, we can make a significant positive impact. So thank you so much for those words. So if you hang out, we will take pictures with you in a few minutes. We got to memorialize this event. It is now my pleasure to introduce to you my colleague, Christine Paduvillo, who is a social worker by background, but she manages a community outreach team, infectious diseases and special programs, and is our vice president of programs and social services. And she'll introduce the all-star team to you. Thank you.
Hi, everybody, and welcome, and thank you for being here. Thank you to Frederica. Thank you to Dr. Ojukutu for that wonderful presentation. This day is about hope. We know that there is a lot of work to do, as we saw in the presentation, but we are thankful and we are hopeful for this opportunity to do this work. I cannot introduce the team any better than they can introduce themselves. There's a lot of us here to talk a little bit about what this program is. Coordination was the emphasis of the presentation. You know, when we talk about the work that we've done here at Whittier, we've had a behavioral health team. We've had an infectious disease and special populations team. This program is bringing us together in a true, coordinated, integrated effort, and we are thrilled. And the idea that we are not just focusing, when we say risk, it's not about just a corner. This is about the corner, yes, but about everyone who comes into this clinic. For those who are using substances right now, we need to screen for their risk of HIV and educate on their risk of HIV, STIs, Hep C. For those who are getting HIV treatment, we need to address and be able to assess their mental health and their substance abuse needs. So we are thrilled about the opportunity to really make this a comprehensive, tri-focused program. So I would like the team, there's many of us, I'd like the team to stand up. I did prepare them for this, so I don't look too shocked as I'm looking at some folks, to introduce themselves and their role, because as Frederica mentioned, there are several stars in this room, and I want each of them to get their minute to shine brightly, because every touch, every interaction with a patient can lead to recovery, can lead to an improved health outcome, and can lead to a stop of this epidemic. Okay, so I really do want the team to introduce themselves, and stand up everyone now, and we'll go around the room and introduce themselves, and we'll just start with going around in a circle. Starting off with you, Lourdes.
Welcome everyone. My name is Lourdes Gonzalez, and I'm a medical case manager and peer support coordinator.
Hello, everyone. My name is Diana Asuncion, and I'm the senior medical case manager.
Hi, I'm Amanda Romero, and I'm the
Day 4 of her, day 4? Yes?
Day 5.
Day 5, yes.
Good afternoon. My name is Lamar Booth, and I'm a community health worker.
Good afternoon, everyone. My name is Frank Mitchell. I'm the HIV program coordinator for our prevention team.
Good afternoon, everyone. My name is Doris Hill, and I'm a care program located inside behavioral health.
And behavioral health team, oh, I'm sorry, I see some people on this side of the room, Charles. I'm sorry, they're trying to get out of this. Behavioral health, also introduce yourself.
Hi, everyone. My name is Walda. I'm the child and family clinician. Hi, I'm Carolyn Reynolds. I'm one of the associate directors of behavioral health specializing in substance abuse and special populations.
Hello everyone, I'm Maria Betts, clinician in behavior health as well. Substance abuse.
Yes, welcome.
Good afternoon everyone, my name is Brenda Daly and I am the Associate Director of Child and Family Services in behavioral health.
Hi, everyone. My name is Shelly Dyson. I'm also a child and family clinician in behavioral health.
So my name is Charles Paul, and I'm a kid advocate in the reading with ISP block.
Hi everyone, my name is Amelia Fit. I'm the program coordinator for HIV prevention service here at United States. Good afternoon everyone, my name is Leslie McConnell. I'm a behavioral health clinician, primarily working with adult clients, and I work out of the Quincy Commons satellite office.
Hi, I'm Kathy Lash. I'm a child and family clinician, and I work with children and adults.
Hi, my name is Elsa, and I'm also a child and family clinician in behavioral health.
And can we give a big round of applause to this team? Thank you. And everyone, as we were talking about earlier, there is hope. We know that, and we are very appreciative of, again, of our partners with the Boston Public Health Commission, this coordinated effort, because it is a coordinated effort. I hope that as people were introducing themselves, for those who are meeting the team for the first time, really recognizing that this team does reflect the community. when we've addressed some systemic barriers, sometimes people don't feel comfortable coming in and talking to someone who they don't think gets it. I think all of us, doing that air quotes, we don't think people get it. But this room, the people in this room have really been committed to the community. They reflect the community, and again, the superstars of this program. So we are delighted and excited about this launch. And again, thank you for everyone for being here. We are now going to have our panel discussion, and I'll hand it over to Pastor Bell. And for those of you who are on the panel, if we could move to the designated seats up front, please. Yes.
Thank you. Thank you, Christine. Thank you. So it's wonderful, as Christine said, we have a culturally sensitive, but people with lived experiences, people who understand the issues, and can impact the lives of patients. It is now my pleasure to introduce to you the chair of our board, Pastor Gerald Bell. He's also the pastor of Strong Tower Church in Roxbury, and it's wonderful to have Pastor Bell. He's in the community, been a community leader, a faith leader, and much of the work that we have to do is making sure that we're partnering with community residents and faith leaders and community leaders. So it's a pleasure to have Pastor Bell as a long-standing member of the Whittier community. Pastor Bell, and you can introduce the panel.
Thank you again. And beloved, could you please just stand up and shake a little bit? This is so important. I know I might sound like a yoga teacher, but I'm not. All right, beautiful. I just want you to be focused because this panel is extremely important. Thank you, Miss Frederica and Christine. Where are you? Let's clap our hands for Christine and Frederica and the staff. We know the time is short, so we really want to stay focused. What I would like to do, thank you so much, is I'm going to ask and make a statement, and then I'm going to ask 3 simple questions and let you have the freedom and the flexibility to give your perspective. We don't have much time, but we want to hear from everyone. So I'll set everything up in context for us all, which I think we all know, as Christine said, we all get it. And at that same time, could you please also tell us a little bit about yourself and the work, what brings you here. So Senator Diane Wilkerson, Antonio Lillies Heel, Charles Powell, Carolyn Reynolds, and Lamar Booth. Have I gotten everyone? All right, wonderful. Let's give our context to our discussion points so that we can all hear from our distinguished panelists and give us some reflection on this day. The city's Office of Recovery Services has had over 21,000 interactions with people on the street and has issued more than 6,000 referrals to services. Earlier this week, there were 170 available beds in the city shelters for people facing homelessness and substance abuse disorder. The shelter beds are available. The treatment is available, but the number of tents on Mass and Cass continue to grow. So, as I drove past there this morning, grizzled 62-year-old veteran, I shed a tear. I came to Boston in 1983 and lived at what called the nurses building right out of college, and I shed a tear. Pastored in the city, did all kind of gang funerals, I shed a tear. So the question is this: what do we need to do to get individuals from tents to treatment? Number 2, what are the barriers? And please, 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 can you share a success story? Let us begin with the esteemed Senator Diane Wilkerson.
So, context. First, Good morning. Diane Wilkerson, resident of Roxbury. I actually live on Burrell Street. Anyone knows where that is? I'll tell you, ideal sub. So I can see South Bay literally from my porch. I have been serving for the last year or so as the representative for State Rep Liz Miranda on the conversation around, well, it's mass and cast for us, although this is a bigger issue. But that conversation was driven because of the widespread opposition to housing homeless people with addiction history in what we call the Roundhouse Hotel. And I also want to add as the context that in 2005, I wrote the first in the nation statewide commission to eliminate racial and ethnic health disparities. And one of the things that happened in 2005 is finally the American Medical Association issued the report that Dr. Bisola Ojikutu talked about, where they first acknowledged the disparate treatment of Black and white and Latino folks who presented in emergency rooms. The assumption that Latinos and Blacks were exaggerating their pain. And so they were less likely to get pain medicine. And so this is all in some measure connected. So I just want to say a few things about the context for today. First, remember, even though we saw that incredible kind of picture that and by the way, I am doing somersaults about her presence. She associated with the Black Boston COVID-19 Coalition for the last year, so we own her, we claim her. And so when we heard that she was even thinking about this, she called me, what do you think? I had long conversations with her about it, and the prize would be for us. Make no mistake about it. And with that kind of energy, that kind of knowledge, and that kind of optic and presence, I know things can only get better. But here's the deal. The reason why the introductions, when Carolyn made them, were so powerful, and why when Dr. Ojikutu said, that things can get better, I think, this is just me talking, the most critical asset we have in this fight is the cultural competency that you bring. Why? Because we live different. We think different. Our response is different. Do you know how many comments that I have been reading in the last week in the press where people said, how dare they put up tents? Think about that. How dare they take steps to put a roof over their own head because society has failed them? Who we are dictates how we see this whole thing. And it's not even so much about us, because we know that the complexion of the people there run the rainbow gamut, right? So in 2006, Councilor Chuck Turner, late Councilor Turner, and I were fighting with the Sober House on Washington Street. You all know exactly what I'm talking about. We had to go to the clerk in the court to make sure that they stopped referring people there. Why? Because we had parents from across Massachusetts who were emailing me in the State House and him in City Hall asking for us to help them find their children. Then, from Great Barrington, from Haverhill, all they knew is that they were somewhere on Washington Street, right? Now, in the Sober House, and then of course I get the call from the mom whose son died there. He was supposed to be there in recovery. So this is not new for us, that's my point. But what is important, and I'm wrapping because I do want to hear from the rest of you. What's important is that what you bring to this work, you see it differently. You just do. It hurts all of our hearts. I understand the tears because I'm at the point now, because I live so close, I'm driving around it. There's some days I'll go in it because my psyche is prepared, but there's some days I can't. There's some days I can't. And here's my final thought. This is Boston. You know why I say that? We got it better here than most every place else in the state. If anybody's going to figure it out, we're going to figure it out right here. Right? so don't applaud the state, the Baker administration, because they stepped in. You should be asking where you've been. I don't know how this all of a sudden, he's come to save the day. Really? I'm so, like, really? Where you been? So Whittier Street, you've been here. You've been in it, as they say. Continue to be in it. And the rest of the folks are just going to have to catch up to you. That's all I'm going to say.
Hi, everyone. I'm new to this, so bear with me. I thank God for allowing me to be here today to talk to y'all amongst the homeless people. When I walk down the street and I look at them, I look at the people, and every time I look at the people, I think that I wish I can do something for them, like build them. If I have $1,000, I will build them a house and bring them all into the house so they don't have to be homeless. Like, this is ridiculous. I don't like seeing people homeless. When my grandmother was alive, she always liked to help people. She loved to help. If she see anybody in the street, she'd like to feed. And that's how I got into the role of all this technique. Bear with me.
You're great.
I'm just.
Fabulous work you do.
Yes. I just wanted to say I'm from Boston, Massachusetts. My name is Antonio Lyles Hills. I just want to. It really touched me because I know where they've been through, and I know with God's grace and mercy, He's going to help them to get better. And it really hurts me because I know that if I have a group of people that goes to them to give them money and food and offering stuff like that, that would be generous. But I'm just grateful to see that God is using me to pour into them like each and every day, so I don't have to be I don't have to be afraid of going to them and letting them know about God, because they need God eventually, but we have to own up for ourselves to be the best that we can be. And thank you. God bless you.
This right. First off, God is good. I was in the same position they're in now. Okay, shelter, using the whole nine. But somebody reached out and helped me. We need to get people to help them, not just try and lock them up, you know, because that's not going to help them none, you know. Locking them up, they're just going to come out and do the same thing, you know. So we got to get legislature to pick up the slack quickly. I mean, they're running for offices, you know. They talk about doing the work, and then once they get in, it goes to the back burner, you know. We need to get more legislation. If we got to go to Washington, you know, somehow get them from Washington, do that, you know, because there is a couple of success stories. I have one, as a matter of fact. I have, working here at Whittier, I had one of my clients, you know, that was out there. I gave him my number, told him to call me. He called me. And now he's doing much better, okay? Because somebody reached out to him, We have to meet them where they're at. Okay? If we don't meet them where they're at, they're going to continue to stay out there. We got to find out what the barriers they are having that's keeping them from a lot of, I got lost there for a minute. A lot of them are out there because they lost their place. They might have been indulging and using before, but now since they lost their place, they done lost that hope. Okay, we got to give them that hope back. We have to. You know, I used to get on my son all the time, and now by the grace of God, he's doing better. Yes. You know, so I don't know what we got to do, who we got to talk to, but we need to do it.
Good afternoon, I think. Good afternoon, everyone. My name, again, is Carolyn Reynolds. I'm one of the Associate Directors of Behavioral Health Substance Abuse, a specialty. A little bit about myself. This is a second career for me. My first career was in business and corporate. And in college, I wanted to major in. I started majoring in psychology, but in order to graduate, they told me I had to do experiments with mice. I said, that's not going to happen. So therefore, I changed my field. My counselor said, why don't you think of business? Back then, you guys are too young to know what it was called, personnel management. She said, why don't you do that? Give you the people connection and help that you want to do, and you may make a little more money. So I said, okay, I'll try it. So about 15 years I did that, hated it. And so I just said, I'm going back to school, do what I want to do. At the same time, watching family members suffer with addiction, I'm going to be the savior. So I changed my major, went back to school, majored in counseling psychology, specializing in addiction, and learned quickly I can't. They have to save themselves, but I wanted to be the support person to help them do that. So with that being said, something that we learned closely with the outreach team on the mental health side, substance abuse side, and please team jump up and add to it, the barriers to treatment that we see. Stigma, Senator Wilkins mentioned that we won't, because when we do, we don't see people that represent what I'm going through, and therefore I may feel judged by you, or you just don't understand. I am so thankful here at Whittier Street, our behavioral health team represents the community. We also work hard to help our clients in this community, which people of color have a history of doing, the stigma into treatment. You keep your secrets inside, you don't share it, you don't tell anyone. We can't get better if I don't tell you what's going on with me. So those are some barriers to treatment. And then, where am I going? You clean me up, yes, you put me into a shelter or detox, but where am I going after that? Because result of my addiction, I've lost my home. I've lost my social support. I've lost the love and support of my family. I've lost my job. Now where am I going? So we in behavioral health understand that. We try to treat the whole person. We listen to understand to listen. One of the main things that I think we do a great job of is help folks uplift their spirit. I'm so broken where I'm looking down and down is looking up to me. So we try to help uplift their spirit, uplift their self-esteem, focus on their strengths versus their weakness, help breaking the cycle of recycling. Because of my addiction, I lost my home. Because of my home, I lost my family support. I've lost my job. I lost my job. I go back to using, so I go back to using. I go back to jail. We try to interrupt that and give them the resources, the support that they need. We also, and I'd like to give kudos to Frank and the outreach team, we pay attention. We listen to their stories and what they're telling us, barriers. So understand, this is this person's barrier, Carolyn, so I need your team to understand that to help sustain them. and focus on their strengths to sustain them, to sustain their recovery, to help, give them the resources they need to sustain life. I need food, clothing, and shelter, but there's so much more that I need, especially if I'm battling substance abuse and my mental health issues. So we got to address the whole person. Thank you.
Good afternoon. Good afternoon. My position here is a community health worker. My job is to go out on mass and cast every day, to go out there and try to get people tested for HIV, brought in for services, or whatever it is that they need. I'm one of the people that goes inside the tents and talk to the people. That's my job, man. It's deep, but the end result of the story is that I started off as a patient here at this clinic. Seriously. And Miss Frederica, under the tutelage of Frank Mitchell, they picked me to go out there, man. They said that I fit the criteria, and it seems like I could go out there and I could talk to the people, man. And from that point on, man, it has been a blessing as far as I'm concerned. To work here, to go out there and try to link people into care, man, to get them tested. Anything that they need, we try to take care of. And that's a beautiful thing, man. Like, to me, Whittier Street has been the champion before anybody else. No one can come before Whittier and say that they haven't been out there doing it, because they have been doing it from the beginning. If they pick me, then they, you know what I'm saying? That's why I'm saying that it's a blessing, man, seriously, man. And I think that the solution to the problem is we have to find out, how did it get to where it's at? Because it didn't just happen overnight. They didn't just wake up and say they wanted to be drug addicts and then they were on the mile, man. Because seriously, from one week to the next, the streets were empty. Yes. And then a week later, it was one side that was full and another side was full. I'm trying to figure out, if you let it get to that point there, why did you wait so long to try to correct the problem? Y'all have a good day, and thank you, man.
Two things. We're gonna come to you. Two things before we wrap up. I got to give you my 2 points of barrier. Evicted on the street, 13, age 13, 17, and 19. Alcoholic mother. She died alcoholic. What do we know? You can't make nobody get off dope and alcohol and drugs. They gotta want. So the first barrier is you gotta come to know yourself, and you gotta say, I want help. And you gotta have some loving people around you. But I tried to make my mother do it. She can't do it. She couldn't do it. 2, do you heard the doctor? I'm getting ready to cry because I'm old enough to cry because I like crying these days. But the second thing is, you heard the doctor talk about her people. We need to talk about my people, the church. And thank God for Frederica and Whittier, because my mindset changed while I was here against LGBTQ and all of what I learned. I thank God I've put down all my barriers from the church. We have failed the people, and if we ever want to preach who is my brother's keeper and who is the good Samaritan, then we as the church need to face it ourselves and look inclusivity with all of these. And I'm the first one to say thank you. I'm sorry. I didn't learn that in the church. I learned it here at Whittier when I learned that you help everybody. Everybody. Color, race, creed, sexual orientation, and we need to do the same in the church. I'm good, because I'm gonna preach if I keep going. Stop me.
Thank you so much. This is only the beginning. We have a lot more work to do, and we are so fortunate and blessed to have all of you and we will, take notes and develop action steps out of what you just suggested to us. So thank you, and lunch is being served. Thank you.